Now look at the notes for Extract 1.
You will hear part of a consultation between a GP and a patient called Mrs. Brownstone. For questions 1 to 12, complete the notes with a word or short phrase. Hi, Mrs. Brownstone. How can I help you today?
Hi there, Dr. Rivers. I'd just like you to do a test on my waters. I've had a few problems recently. I have to go quite a lot more, and it's started to burn a little and just been a little bit uncomfortable.
I see. How long have you had these symptoms for?
Well, it's been sort of goes on and off for about 3 weeks, closer to a month, really. Some days it's better than others. I don't take too much notice. I put a lot of it down to age, but I don't think there's anything really serious, but just wondered. It seems a bit strong at the moment.
And have you had this sort of problem before a lot or not?
Oh, yes, it's happened quite often over the time. Normally just antibiotics clear it up. I'd say I've been treated for this, at least 5 times in the last 10 years.
And you've left it for a few weeks before coming in to see me. Do you sometimes get symptoms that come and go like this?
Yes, they do. And I just try to drink more, which I'm very bad at, drinking water and such like, but I try. And it usually goes. Well, it usually just goes off by itself, really.
Okay, and what about nighttime? How are you at night?
Oh, I'm up and down a lot. 3 times out in the night at least, every night. And it's more painful at night time, funnily enough. And it's much more urgent. At night there seems to be a lot of pressure. I think it's been going on for such a long time it's becoming normal.
Right, okay, well, that's not something we want you to be getting used to. Let's see what we can do. When you've had these symptoms in the past, you've had the antibiotics, did it calm it down?
Yes, antibiotics seem to do the trick.
And what about accidents? Any accidents with the waterworks?
No, I just have to make sure I get there quickly. I do find when I've been sitting for a while, once I get up, I've got to go immediately. So I always want to know where the loo is wherever I am.
But if you cough, sneeze, or laugh?
No, nothing like that.
Yeah. So what I'm keen to do actually is just to give you a short course of antibiotics and see how you get on. If you've had this similar things in the past and antibiotics have helped, I think that the first step is to see what happens if we do the same thing.
Right. I'm not sure if this is important or not, but I had a series of water problems way back, 25 years ago or so. I had a colposuspension in 1980 something. I was 50. And that worked. It worked well, I think.
Good. Okay, let's keep that in mind, but we will start with some treatment. But if it's not improving, we'll need to reassess the bladder function a bit more closely.
Right, okay.
Are you allergic to any medications as far as you know?
Yes, there's a few. Septrin, Amoxil, and... Oh, what's the other one? If you can just hold 2 seconds, I'll tell you. Keep it written down so that I can... So, Septrin, Amoxil, and Trimethoprim.
Trimethoprim. Glad I knew that, because that would have been my first choice. You've had something called nitrofurantoin?
Yes, I've been okay with that one. The nitrofurantoin, I've had it before for 5 days.
Right, thank you. So, as you asked for, I will get you to provide us with a sample we can send to the lab. I think that what I want you to do is drop back in and see us in 5 days, and we can review the results and discuss how the medicine is working, okay?
Extract 2, questions 13 to 24. You hear a physician talking to a patient called Mr. Tulinsrue. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. May I find out what the problem is?
I've been experiencing the symptoms of heart failure for the past year, doctor. Although it appears okay in general, I feel a lot of stress and fatigue. I've also noticed shortness of breath with exertion. I am getting attacks of severe shortness of breath and coughing that usually occurs while I'm sleeping. I have developed edema and had a mild leg swelling a while ago.
Do you have severe chest pain called angina, palpitations, or syncope?
No, doctor, but I feel some irregularity in my pulse. Over the past 10 months, these symptoms have been gradually worsening. Over the past year, I've gained about 20 kilograms in weight, doctor.
What's your age?
63, doctor.
Have you had any previous illnesses?
I had right inguinal hernia surgery 7 years ago. I had trauma to my right thumb.
Do you have diabetes, mellitus, or heart murmur?
No, doctor.
Do you smoke or drink?
I don't smoke, but I drink.
Tell me about your family history. Any illness?
My mother's alive at 92. My father died at 76 of a heart attack.
Are you taking any medications?
Yes, doctor. Aspirin, 81 milligrams daily, and chlordiazepoxide and clidinium combination pill at 5 milligrams or 2.5 milligrams, 1 tablet daily for stress.
Are you allergic to any medicines?
No, doctor.
Okay, well, according to my comprehensive cardiovascular examination, your blood pressure is 120/70 in each arm seated. Your pulse is 80 beats per minute and regular. Your breathing is 2 times per minute, and that is unlabored. Lungs are clear to auscultation and percussion. The first and second heart sounds are normal. You have a fourth heart sound and a soft systolic murmur. The precordial impulse is enlarged. Your electrocardiogram shows sinus rhythm with left ventricle hypertrophy. Your peak oxygen consumption was 19.7 milliliters per kilogram of body mass per minute, which is consistent with mild cardiopulmonary disease. Laboratory data shows your thyroid stimulating hormone 1.33. Your glucose is 97 and creatine 0.9. Potassium is 4.3. I reviewed your echocardiogram thoroughly. That shows a dilated cardiomyopathy with ejection fraction of 15%. Your post-stress ejection fraction is 33%, and left ventricular cavity appears enlarged. This appears to be a newly diagnosed dilated cardiomyopathy of uncertain etiology and dyslipidemia. I'm going to prescribe angiotensin converting enzyme inhibitor lisinopril 2.5 milligrams daily and a beta blocker carvedilol 3.125 milligrams twice daily. In addition, you could benefit from a loop diuretic, furosemide 20 milligram daily. I don't think you need a defibrillator right now, and after 3 months of medication, I want you to go on an echocardiogram. If your left ventricular function has not improved, then you would benefit from a prophylactic use of an implantable cardioverter defibrillator. So continue with these medications and meet me after a period of 3 months.
Thank you, doctor.
In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a registered nurse explaining to a student the uses of a peak flow meter. Now read the question.
Dr. Matthews wants us to monitor Lucas Young in bed 6 using a peak flow meter. Are you familiar with this device?
I've seen them before, but I thought they're only used in special circumstances.
In short-term monitoring, they can be very useful for a number of reasons. For example, if a patient has suspected occupational asthma, the peak flow meter can help diagnose or exclude the possibility of asthma. It's also handy in monitoring a patient's response to new medication, or in this case, a change in dose. In most cases that I've witnessed, they're used to calculate the trigger point for a written asthma action plan.
I see.
You hear an emergency department physician discussing a patient with a colleague. Now read the question.
In bed 5, we have Jason Burgess, a 6-year-old boy with a suspected accidental minimal ingestion of eucalyptus oil. His initial symptoms included mild CNS depression, drowsiness, and ataxia. On admission, his breath smelled very faintly of eucalyptus. At the time of the incident, his mother was in the bathroom where there was an exposed bottle of eucalyptus oil on the vanity. She was distracted only momentarily, but when she looked back, she noticed oil droplets on the front of Jason's shirt as well as on his lower lip and chin. She cleaned his mouth and changed his clothes and thought he was fine, but around an hour later, she noticed his change in demeanor. We need to continue to monitor his vitals and watch for any changes in his current condition. He's appeared more alert over the last hour, so it's looking positive, but we can't be too careful in a case like this.
You hear a nurse educator briefing a student nurse about the importance of compression stockings. Now read the question.
Compression stockings are specifically designed to apply pressure to the lower legs, helping to maintain blood flow and reduce discomfort and swelling. They fit very snugly to help the body's circulation, but that means they can be rather uncomfortable, so not all patients like wearing them.
So does that mean all patients have to wear them?
Not all, but we encourage their use for post-op patients, and especially for particular conditions, such as Mrs. Jones in bed 6.
Okay, so why is it so important for her? I was told they are very expensive.
Mrs. Jones suffers from lymphedema, which is a chronic condition that causes swelling in the body's tissues, but particularly in the arms and legs. Compression stockings can help blood in the veins return to the heart, and a patient's health should never be compromised or impeded by cost-cutting measures.
You hear an audiometry nurse talking to her colleague about a recent patient. Now read the question.
I just had another patient who works as a bartender and now has noise-induced hearing loss. That's the 3rd one this month.
It's very common, but then it's their choice to work in that environment.
Of course, but I doubt they go into it with the intention of losing their hearing. Surely the employer should be held accountable.
Perhaps, but it's still a personal choice.
Yeah, I guess.
Plus, they earn more than us with all the tips they get. When was the last time we were given a tip for what we do?
You don't expect to get tips, surely.
Of course not. I'm just saying they get paid very well for what they do. They don't have to spend money studying, and they still do well for themselves.
Yeah, true. But being paid well doesn't justify losing your hearing.
I don't know. It seems like a fair trade to me.
You hear a nurse giving instructions on subcutaneous injections to a patient. Now read the question.
Subcutaneous injections are given with a very small needle that causes little or no discomfort. It's important to find a comfortable, well-lit working place to do the injection. Remember that preparations for each injection are as important as the injection itself. Plan to do your injection at the same time each day. Consistency is key. Make sure it's the medication your doctor prescribed and always check the expiration date on the vial. If it is past its expiration date, make sure not to use the medication. The same goes if you see any particles or discoloration. Just take it back and check with your doctor or pharmacist. You should get into the habit of cleaning your work area with soap and water. Dry off the work surface with a clean towel and then begin to assemble your medication, disposable syringe and needle, your alcohol swabs and puncture-proof disposable container.
You hear two nurses at a training day discussing a lecture. Now read the question.
I can't believe we just wasted 20 minutes listening to a lecture on how to deal with patients with a fear of needles.
Didn't you find it helpful?
Oh, come on. That entire lecture was aimed towards a student with zero experience.
I know what you mean, but I found the tips on how to get them through it quite interesting, actually. Especially from before you begin, like watching their body language or asking them to lie down. I mean, some patients faint before you even touch the skin.
Didn't you already know that? You've been nursing for years. It's so obvious.
Of course it's obvious, but it's good to hear it, especially knowing I'm not alone in finding my patients with needle phobia difficult to handle.
I think I should have gone to the respiratory review on lung sounds.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
You hear an interview with an optometrist called Henry Chapman, who's talking about the impact of macular degeneration. You now have 90 seconds to read the questions.
We are talking today with Henry Chapman, an optometrist with a special interest in macular degeneration. Mr. Chapman, firstly, what is macular degeneration and how did your particular interest in this disease come about?
Macular degeneration is actually the name given to a group of chronic degenerative retinal eye diseases that cause a distortion or progressive loss of a person's central vision, but leaves the peripheral or side vision intact. Say, if someone with macular degeneration was facing me now, they'd see my arms and legs, the area around me, but my face would likely be obscured by a dark or empty space. They experience a dreadful sense of being disconnected or cut off from everyday life. As an optometrist for 30 years, I've had my share of cases, and every new patient is like a spark because the impact of each accumulates over time to a kind of, almost what you'd call a fixation, I guess. Even after all these years, however, I was still shocked to hear my sister had recently been diagnosed with macular degeneration, and because of that, I've now also seen firsthand what this terrible disease does to the entire family.
What's the most challenging part for those living with macular degeneration?
Take a recent patient of mine called Robert. He was 55 when he first noticed the symptoms: blurred vision, distortion of straight lines. The effect on his life was profound, and that's the tragedy of this disease. He was working as a driving instructor, then suddenly had to resign, but still with the financial burdens of daily life. His passion for carpentry or even basic reading fell by the wayside. Worst of all for Robert was no longer being able to see his grandchildren's faces clearly, which was obviously very upsetting. Unfortunately, he also experienced depression for a time. This may not happen to everyone, but it's certainly more common than people realize.
What can be done for patients such as Robert?
This is a disease that's typically related to aging, which is the commonest risk factor, but it's certainly not a normal or inevitable consequence of getting old. So although older people are generally more accepting of the extra baggage that comes with aging, it's still difficult for many to accept and discuss the changes associated with macular degeneration. There's a tragedy attached to any disease or illness, but vision loss also carries some major disruptions to a person's lifestyle, as well as mental hurdles, like few other diseases do. I feel that's something that can at times be neglected. There are support groups, but I'm talking on an optometrist level. My job is to help diagnose and treat a patient. But what of their additional struggles? That's where I'd like to place myself a little better, and allow patients like Robert the freedom and availability to open up.
And do patients ever volunteer to express their fears or frustrations to you directly?
They do, but in the beginning what I see is their brave face. They often say, "There's always someone worse off." And that's an admirable trait, but reality soon rears its ugly head. Because macular degeneration doesn't result in total blindness, sufferers are left with partial vision, and I suspect that many patients may genuinely interpret this as being somehow less significant than total blindness, like they don't have the right to speak out. The reality is, of course, that sufferers of macular degeneration have many of the same fears and impediments as those who've completely lost their sight, and yet they're worried about voicing this. So it's imperative that we not only actively listen, but also encourage and support them to openly share their stories.
Can you give us an example of how you've changed the way you treat your own patients?
Sure. I have a patient called Jennifer. She's 62 and has late-stage neovascular or wet macular degeneration. This is caused by the formation of very fragile blood vessels which leak fluid and blood within and under the retina. It also leads to a rapid loss of central vision as opposed to the dry kind, which is a far slower decline. Therefore, it came as a great shock for Jennifer, in turn making her a perfect prototype, if you will, in trying something new. I allocated just an additional 10 minutes to each of her appointments and explained it was for an open discussion. This extra time gave me the opportunity to delve a little deeper into how she was coping with the rapid changes she was experiencing and gave her more freedom to discuss her concerns. The positive change in communication was extraordinary, so I adopted this for all my patients thereafter.
So what, if anything, can be done to help prevent macular degeneration?
Research is ongoing and advancements in treatment are being made daily, and this needs to continue. But you can't leave it up to researchers. I believe in what the individual can do. This means that any difficulty with vision should never be dismissed as part of aging. In its early stages, Macular degeneration may not result in noticeable visual symptoms, but it can be detected with an eye test. If people want to save their sight, I can't stress enough how crucial the early detection of any form of macular degeneration is. The sooner that this disease is detected, the earlier that steps can be taken to help slow its progression and save sight through treatment and necessary lifestyle modifications.
Thank you for sharing.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a hospital doctor called Dr. Keith Gardner giving a presentation about some research he's done on the subject of staff-patient communication. You now have 90 seconds to read questions 37 to 42.
Good morning. My name is Dr. Keith Gardner, and I'd like to talk to you today about some research I've been involved in concerning something that affects all health professionals, staff-patient communication. Now, firstly, let me reassure you that in feedback, patients seem positive about the way information is communicated to them. But I recently decided to explore the issue in more detail when I was in a hospital with a patient and witnessed for myself what can result when a healthcare professional assumes they've made themselves clear to a patient, when in fact they've been anything but. Luckily, I've had very few complaints made against members of my team, but the potential is certainly there. So first, let's start by looking at a typical hospital admission for an inpatient. And the first communication they have about any procedures they are to undergo. On arrival, a patient will complete necessary paperwork. Various staff will talk to them about their treatment during their stay, which is designed to reduce patient anxiety. However, from some patients' point of view, this interaction can seem very complex and difficult to take in, especially at a time when they're not at their best physically or mentally. So it's doubly important to check that any communication has been understood. Now, to illustrate what I'm talking about, let's take a hypothetical situation. I often use this because it highlights the potential consequences of poor communication. A man in his 80s is admitted to hospital, despite his protestations, with ongoing severe back pain. On investigation, it's found his cancer has spread. The outlook is poor, and further compounded by his becoming depressed and refusing to eat while in hospital. A feeding tube is inserted, a procedure which the patient complies with, but which his family members query. The doctor on duty updates them, assuming they're aware of the severity of the patient's condition, when in fact no such prognosis has been shared with them. An extreme case, but a plausible one, nevertheless. In order to find out exactly what inpatients felt about the service they were receiving in this hospital, we conducted a patient survey. The questions were carefully targeted to capture patients' opinions about the effectiveness of the communication they'd been involved in during their stay. The survey questioned patients on both what they had expected prior to admission and what their stay was really like. These two scores were then used to calculate what's called a gap score. The survey also included questions to measure the patient's behavioral intention, that is, how willing they would be to return to the hospital for treatment. Patients completed the survey themselves, and results were then processed with the help of medical students. Now, the survey produced some interesting data about communication, including both praise and complaints. Clearly, in a hospital situation, staff are dealing with confidential and sensitive information, which must be communicated in private, a situation which can be difficult to achieve in a large and busy hospital. However, we scored highly on that point, and we were also pleased to note that staff did manage to communicate in a manner that treated patients with dignity and respect. Of course, staff also have to ensure patients fully understand what's been said to them, and this last point's where we received the most negative feedback. Both patients and relatives noted a tendency for professionals to resort to the use of jargon and complex terms when explaining both diagnoses and procedures, which left some patients confused. However, patients were generally satisfied with the information about any follow-up treatment provided after discharge. Also, once we'd sifted through all the results, a clear pattern began to emerge regarding the care given by nurses, which I found particularly interesting. I'd assumed that having a number of different nurses attending to a patient during their stay was a good thing, because you need enough staff to cover the various shifts and attend to patients' needs. What I certainly hadn't expected, though, was for patients to say they felt their recovery was faster when they had to communicate with only a small number of nurses. In other words, when they were surrounded by familiar faces. The findings aren't conclusive, and more investigative work needs to be done on a bigger sample, but it's certainly food for thought.